Good morning, everybody. Welcome to this Adult Social Care and Public Health Select Committee meeting. My name is Councillor Jodie Stoll, the Chair of the committee, and I would like to welcome you to this meeting that is being broadcast live and recorded for publication. Okay, we will move to item number one, which is the minutes. So could I ask the committee to approve the minutes of the last meeting, please, with a show of hands? Yep. Okay, thank you. And Dom, could we have any apologies for absence?
Thank you, Chair. Councillor Sam Smith is substituting for Councillor Roger Jackson, who sends apologies under the category medical reasons. Councillor Wheatcroft sends apologies under the category other reasons, and Councillor Rory Green sends apologies under the category other county council business. Thank you.
Thank you very much. Okie dokie, declarations of interest. If any councillor or officer has an interest in any matter that is on today's agenda, you should please declare it now. Please raise your hand if you have an interest to declare. If you have an interest to declare, you should state what type of interest it is and to give brief details. Thank you. Okay, thank you very much. Okay. Moving swiftly on, we'll move to item number 4, which is the Joint Carers Strategy Progress Report. And we'll ask Councillor Barry Answer, the Cabinet Member for Adult Social Care, to introduce said report. Thank you. No interest, Barry, no? No, no problem. Thank you.
I think this is about obviously about what's refined within the Care Act, and it's regarding obviously aged carer strategy, and there are lots of issues in there that cover lots of issues, a lot of items in this report, and I do think that in this report we do need to, without doubt, follow the guidelines and really incorporate all of the issues and the progress looking ahead. And I'm sure that after we've had that discussion, I'll probably get a little more information from what people are wanting to add into that report. I think it's a good item that we need to deal with. It's a lengthy item, and I do think that I'd appreciate everybody else's input into that. We've all read the report, we've all got that report, so I'm looking forward to that.
Presentation, would you like me to go through the presentation?
Yeah.
Thank you. Okay, does any of the officers have anything further to add regarding the report?
You okay for me to do the presentation?
Yeah, I'll turn your microphone on. I can't see you.
Do you want me to read? Good morning, everyone. I'm Katie Ball, Director of Commissioning. Really pleased to bring a presentation on this item to accompany the paper. Really important area is our all-age carers strategy. I thought it might be useful just to give a little bit of context and then talk to you about the progress that we've made in terms of impact for people. So we have an all-age carers strategy, and that was co-produced with carers, and we have had a year 1 impact report, and this is our year 2 progress update. So just, I know this will be very familiar to some people, but not all. So a carer is somebody who helps another person, usually a relative or friend, in their day-to-day life. It's not the same as our paid workforce. Unpaid carers are supporting unpaid carers is part of our Care Act. We also talk about young carers, so that's a person under the age of 18 who provides or intends to provide care for another person, and that's part of our Children and Families Act. And we have had carers as young as 4 and 5 that are supporting with some household tasks, often for a parent. And then we've got a parent carer, that's a person aged over 18 who provides or intends to provide care for a disabled child for whom the person has parental responsibility. That's also part of our Children and Families Act. The most common reasons or tasks that a carer might do tends to be household help, such as preparing meals, doing shopping or laundry, and housework. The second most common reason is helping with paperwork and financial matters. Some key stats for you. 5 million unpaid carers nationally, and in our last census we had over 82,000 self-reported carers in Nottinghamshire. Over 1,000 of those were under the age of 16, and we had 2 areas of the county that were the second and third highest areas for England in terms of numbers of carers, and that was Ashfield and Mansfield. Our percentage of the population who said they carry out caring tasks in Nottinghamshire was higher than the national average as well. We also know that we've got some underrepresented groups and some less heard voices. So we worked with a group of carers to produce our carer strategy, which was really important so that we could understand what was most important to carers and how to help our carers. So it's an all-age strategy that was set up for 5 years, and we're bringing you a progress update from year 2 today. For 18 months, we had a carers group that met with us every single week, and that group now meets about monthly. And that was to not only set up the carers strategy, but then to work through all the different types of support to carers. So how we can make sure we've got good information and advice, how we can remodel short breaks for people, for example, that actually fit with people's lives. So for example, sometimes, so we thought people might want whole days or overnight support. Sometimes people just need an hour to get to the dentist, for example, to be able to meet their own health and wellbeing needs. And this strategy is joint between the City and County Council and our ICB. It covers a range of areas. In terms of themes. So it's about the right support for people, access to good information and advice early, being able to access a break from their caring role, and support to look after themselves both physically and mentally, and being listened to. And it covers 10 components, which you can see on the screen, which are reported in terms of progress to our Carers Implementation Board every 6 months. So in terms of progress, we have a carers hub and a young carers service. And in terms of some of the things, in terms of progress and impact for people, they've supported over 1,600 carers in total during the last year, of which over 1,300 of those carers were new. There's a monthly carers newsletter with lots of information that goes out very widely. Those services have worked with a range of other organisations like local gyms to try and get some free support and some cheap support for people to look after their own mental and physical health as well, which has been really good. And we're trying to be as creative and wide as we can about some of that support. They've launched a parent carer support group that's been co-produced, and you can see a range of areas for young carers there in terms of over 700 young carers have registered with the service over the last year. Many of those are new referrals. We have over 250 young carers that have got free travel cards, which has been really important for them to be able to access opportunities. And lots of one-to-one support hours, and providing some fun when our young carers are having a break from their caring role as well. We've worked really widely to make sure, because lots of people don't realise they're a carer in the early days of becoming a carer. So it's really important to help people to recognise that they are becoming a carer so that they can access help and information early. And many of us in the room will recognise that journey as well, personally. So we've worked very widely with a range of schools to make sure that schools have got carer champions and good advice to be able to identify young carers. We've worked with a whole range of private, voluntary and public organisations, 75 GP surgeries. We've done a roadshow that's had over 7,000 visitors come to it. And we've set up in Nottinghamshire carer-friendly employer awards, and the council is going to be receiving that award itself next week, which is brilliant. It's about being a good employer and recognising that in most organisations there will be employed people that are also unpaid carers in their own life and that might need some flexibility with things like taking their loved ones to an appointment, for example. We have a range of information, so we've got a co-produced Do You Look After Somebody booklet, which is information for carers, but also advertisers, how carers can come and get involved in shaping support so that we get it right. We have a big annual report that you've got access to read a wider impact report, but I've got some stats from an adult social care perspective as well. So although we're working with more carers, we're actually, I think, doing a better job at giving information and advice early, because we've seen 11% less carers want or need a full carers assessment because they're getting the support earlier, which is really important. You can see that we have supported nearly 4,000 all-age carers with a new carers assessment or a review. Over 2,500 all-age carers receive a personal budget or a direct payment, which gives flexibility about the type of support that is right for them. We have a waiting well pack for those that are still waiting for an assessment or a review. We've talked about technology-enabled care a lot, and we take a think family approach. We are increasingly using technology that might be for the person that's being cared for, or to help the carer with some of the tasks that they are helping their loved one with. That's been really important. We hear loads of stories of difference about technology, and we've also, in the last survey that we did with carers, we saw an 89% reduction in stress and anxiety because the technology was alerting them when their loved one needed something or might have had a fall, and some of those reasons. We've made a lot of progress in reshaping our short breaks. We're also recognising over 30% of our carers provide over 50 hours a week of care to some of their loved ones. And when they do get a break, because when you're providing over 50 hours a week, you often don't work. It means you haven't got access to much resource to be able to look after yourself. So we did have a £30,000 budget that came from a COVID outbreak management fund, which was at the time, we don't have the comp funding anymore, but we've had that £30,000 pot that has funded small things for people early to be able to look after themselves and to avoid a family breakdown in being able to continue to care. And I just wanted to flag how important some of those small amounts of funding have been to people, that when they're getting a break, they've then been able to go and do something to support themselves. We've changed a lot of our internal systems. When we are supporting people with an assessment or a review, we make sure that's really strengths-based. We look at the whole family. It's a think family approach. Carers are involved in the assessment of their loved one, and we're hearing that that has been a much better process. We also have a dementia wellbeing service, which is really important too. And we've been working on the fact that we've got a lot of less heard voices, and recognising that and being more creative in the ways that we are talking with some of those groups of people and making sure that we're tailoring support in a better way. So a couple of examples are with our deaf community. We've now got a British Sign Language video explaining what an unpaid carer is so that people can recognise when they are becoming a carer. We've got an easy read version of our Do You Look After Somebody Carers booklet. And another example, carers that are looking after people who use substances and alcohol. We've been working with an organisation called Hetties to set up a new group for male carers, for example. So lots of things that we're doing for a range of groups. These graphs, you don't need to see the information is in the report, but this just shows that although we're working with more carers, because we're giving that information and support earlier, actually less carers want or need a full assessment, which I think is a good sign that we are supporting people earlier. And then just talking about our own workforce, we know that 1 in 7 employees have unpaid caring roles. We have known that we do have carers that leave work or study due to their caring roles. So it's really important that we understand that. Our managers in our own organisation are able to recognise and have conversations about being a carer and being appropriately flexible to be able to ensure that someone can keep working and have some flexibility for their caring role. And to where we can be flexible about working arrangements. Some people want to reduce their hours so that they can keep working and still be a carer. And lots of things, like we've now got a carers peer support network group as part of our council. We've introduced employee carer champions and doing lots of things. And we're very excited to be receiving the Carer Friendly Employer Quality Award. And then also in the report, we've listed a range of areas that are priorities that have been co-agreed with carers for this year and the next few years. So I'll pause there. Thank you.
Thank you very much. Any officers present, anything that you would like to add further to what Katie said? No. Okie dokie. Okay, in that case, we'll move the recommendations as detailed in the report. And if I could have a seconder, please.
I'll second that.
Thank you very much. Okay. All right. What I'm going to do now is open the floor for debate. However, before we do that, I would just like to just touch on what I said last time on the last meeting, and for the benefit of those present, if we could try and keep the questions, one question, one answer, and then we'll permit a follow-up question, and then before we move on to somebody else. And obviously, if there's time, then we'll go back round again. Is that okay? All right. Please, questions. Thank you. Councillor Curley.
Thank you, Chair. On that, about one question at a time, I've got quite a few because of the report. Now, some of those questions have sort of been answered in the presentation, but I think they're relevant to still ask. So I've got quite a few questions on this paper, so I hope I'm allowed to ask them, even if it's one at a time. Yeah. But I'll start off with my first question. You sort of answered it. It was about the fact that the national average has gone down since the census. And it didn't really say if ours had gone up or down with that until you went further on in the report, 21, 31 and 36 paragraphs, which sort of demonstrate that. So my first question then really is why do you think we are bucking the trend and it's going up rather than nationally where it's actually going down? You know, if somebody could ask me along those, answer me along those lines, please.
Thank you. As you say, there is that trend nationally of things going down. Locally, we also saw the same on the self-reported carers in the census. But what we do know is we didn't capture a lot of people in that census. The census was done on the back of COVID, and lots of people picked up new caring responsibilities during COVID. We weren't able to be out there talking to people, giving all the same information we normally would, and saying, you do know that if you're doing your shopping for your neighbour, that is still a caring role, for example. So we think that actually the numbers remained stable, if not going up slightly. but because people just weren't aware they were carers, they weren't self-reporting through that census, which is why it looked like there was that dip both locally and nationally.
Councillor Butler.
Thank you. Well, there's no doubt about it that carers, whatever their age, I mean, they're absolutely unsung heroes, aren't they? And that's why this strategy was brought in, because they have been unrecognised, and there is so much to take in on this, and to show our appreciation to the work they do, and I'm sure that we are. But the thing that really gets me is the young carers. You absolutely feel for youngsters, sometimes as young as 4 or 5, and you can't imagine them being carers, but they are. But it's so important we recognise that, and it appears to be the case that we are. A couple of questions, though. In paragraph 31, you report that you supported 527 new young carers in 2024-25. And then in paragraph 32, we got 742 are registered with the carer service. So I mean, that seems an extraordinarily high number in 1 year, which takes you up to a total of 742. So what happened? Is it simply because of this strategy, or what was it that caused that seemingly very high number of new carers? I've also got another question to do with young carers as well, but I'll just let you pick up on that one. Thank you.
So there were a couple of things happened there with the young carers. So as the strategy was implemented, we recommissioned our carer services, the young carer service being one of those. We have to ask permission when we move services to move all of our young people over. We lost quite a few young carers during that process that we're now picking back up. So they'll be registered on the service as a new carer. So that's part of it. That's part of the reason that number went down and then went back up again. The other bit within there, though, is that really targeted work we are doing with schools. We get into lots and lots and lots of schools and are reaching many, many more young carers than we did before. The schools are doing an amazing job at supporting carers and letting us in and working with us. At one point, we were having 40 new referrals through every single month for new carers, people we'd not seen before. So we know that that work is really making an impact. The other bit that's made an impact is that offer of those free travel cards, and we saw lots of young carers come forwards when they knew they'd get free travel for engaging and being part of this, and haven't just done that, they've then registered with the service and been part of that much wider support. So there's kind of 3 elements to it. So it's not a very simple answer that we can carry on doing this, but what we can see is we're now reaching more than 50% of our self-reported young carers. So we know that it is working, but we've still got room to go.
Thank you. So it's not necessarily all new young carers. It's re-registering in effect then, because I just wondered if there had been some sort of big issue that could have caused that. Now you mentioned schools. You're working with schools, which is in the report, which is great. Are we confident, or how do we know that all schools are aware, especially because we're in a world of county council schools, we've got academies and other schools as well. And again, because this figure we mentioned earlier on about the number of really young carers as well, we're also talking about primary schools. Are we definitely engaging with all schools? You said we're working with a lot of schools. So what are we doing to try and ensure that all schools, because it worries me, and I'm sure it worries everyone else, as we've seen so many times, there's probably people out there who need this and they don't know about it, and as a result, their life, their education, their personal life has been affected as well. It could lead to, unfortunate incidents, all the rest of it. So, are we confident we're working with all the schools, and what are we doing about it?
We're definitely engaged in communicating with all schools. There are the odd few that we're working with, and we've not done the full programme yet, but we are definitely working our way around. This strategy is only in its 2nd year. There's one worker for our schools worker, and this is a big county, and it is city and county. What we're trying to do is work with academy groups. So rather than only doing individual schools one by one, we know we can get to see more schools if we go for those academy groups, you know, for things like inset days, for example, or when we have the big staff meetings. We also do lots of work through the Governor Hub process. So we talk through the school governor route, which means we've got another access point in, as well as going through head teachers and executive directors.
Councillor Gowland.
Thank you. I think it's a sort of related question. So that was about children carers, young carers. But I have a lot of questions from parents who are carers, and I'm surprised sometimes because they seem to be very isolated. And I would have thought they were quite well. I expect them to be well sort of locked into the county, and they're coming to me first sometimes, which I'm very surprised about. How does the hub? Because hub implies to me you go to it. How does the hub reach out to all carers, not just young carers?
I'll come in first, just to absolutely agree with that message. All age carers, I think the number one thing that we can do is to work through all of our networks as a county. So the carers that we know, networks that they might be in, getting as much communication in places that people go, and working with employers, schools, GP surgeries, the whole network, to really promote an understanding and a better ability to help identify carers at all ages is really important, because we know for any type of carer, understanding that you're a carer earlier in your journey of caring and being able to get some information and advice so that you don't get to a point where you suddenly feel quite isolated or get to a crisis point with your own mental and physical health is just such an important job. But picking up on the parent carers, there's a range of things that we're doing. Do you want to come in, Anna?
Yeah, so part of it is that joint working between our two services. So although we've got our young carers service and our adult carers service, we're making sure those two services are working really closely together. So obviously one of the key things is we're finding the young carers in schools, they are part of a family network. So they're likely to have this, you know, be caring for a sibling, and therefore there's a parent as part of that as well. So there's some of that work happening with the schools. There's the work obviously happening with the GPs, but then our hub itself is going out there, going into communities, they're being really visible. We don't just work from the one hub location, we're out there in each of the districts of the council. So we're doing that big promotion activity across the board, but also doing some work with parent carers to go, this is parenting, but this is when it tips into caring, because parents were telling us they're not quite sure if they're a carer or this is just parenting, especially if they'd only got one child and didn't have any other experience to sort of layer that against. So we're doing a piece of work around saying to people, you are a carer, and you know, please come and talk to us in our services.
So, in particular, I mean, I guess you go to the SEND schools, but in particular, does the hub provide advocacy? Because this is, again, you know, if you've come with a problem, a lot of the problems are financial, will the hub help them directly with that?
At the moment, we don't offer a specific sort of benefits financial service, but as part of that holistic assessment we do with our carers, we would discuss things like finances, for example. We have our benefits team in the council. We've got our Connect service that support with benefits, for example. So we can direct to other places of support rather than them being the experts in the benefits. They're the experts in carers, but we've got other services that are the experts in things like finances and benefits. So we support to be referred to an expert.
Councillor Gerling.
Yes, thank you, Chairman. On the schools one, so a bit of not advice, but a suggestion, if you like. Because I know how difficult it is to get GPs and schools to engage with things like this, because they always think they're being bombarded with things that they should engage with. And one of the things that's been successful, working with GPs particularly, is the veteran-friendly GP service. So I just thought that maybe an idea would be to have a kite mark, if you like, that this is a child carers or a child carers friendly school, which they can then put on their sensors to say we are a child friendly carers friendly schools. So, you know, make something of it so they actually get something, give them to get that, you need to be doing this. Yeah, and if you pass these standards, you'll get our tick, if you like. Just a suggestion, really. So that was just a suggestion rather than a question, if I may. So I'm just, one of the things I'm not sure about, so this is me learning as well, really, is because I know within my patch I do, I know that I've got young kids that are carers because the mum is an addict or an alcoholic, and they're then looking after their younger brother or sister, getting them ready for school and all that sort of thing. And I just wondered, is there additional support for carers that have and I don't know what we call, I know what we call carers, but I don't know what we call those they help. So do we have something in place to help carers look after multiple people within their family or whatever? Is there something in addition that happens to that? I'll ask another question if you just want me to ask one question at a time. But yeah, that please.
Thank you. I'll come back on both points if I may. The idea about kind of having that quality mark, that's exactly what we're working on, and we agree that it's a great idea as well. So we are promoting all organisations, public, private, voluntary, work towards being carer friendly. And we've got 3 organisations that have got that included, and we're working very actively with 10 at the moment. So I'll check the numbers. I think it's in the report. Yes, we're doing it, but we think it's a great thing because it promotes awareness and gives kind of ideas of standards and things that you can do. So absolutely. The second bit is more nuanced. So obviously we've got children's social care and adult social care that work together very closely. We would have appropriate involvement in a family if there was a parent that was struggling with something like substance misuse. We would hope to be aware of that because schools, children's social care would be working together to support that parent, but we always have a think family approach. So those teams would be looking at that whole family and what support is needed across the whole. And again, that's where we'd be making connections for young carers, but also from a safeguarding perspective. If we'd got a situation in a child's home where there was substance misuse, there's a safeguarding support lens there as well. And equally on the adult side, we take that think family approach as described earlier. So we don't just look at the carer, we don't just look at the people that are being cared for. We think on a whole.
Councillor Wright.
Hi, good morning. I noticed on your slide, Ashfield and Mansfield seem to be a bit of a poor relation. What's the factor of that? And have we got anything in place to improve it in the future?
More JSNA work.
So what we do know is that in Ashfield and Mansfield, we have high levels of need as well. So we know that there are outliers in terms of things like deprivation, health inequalities, and the number of unpaid carers you can see directly correlated to the number of people you've got in your population who are in need of care support, health services and multiple comorbidities. So we can see those numbers directly correlating across there. And that's the reason. So all that other work that we do in our public health space, in our prevention space, across our ICB to reduce those health inequalities down, will also ultimately help to reduce our carer numbers down, because if there's less people needing help, we'll have less carers providing help and support. What we are doing is, though, we know that these are high concentrations of carers, so we're getting really into those communities. Our hub's working with communities. We're working really closely with those GP practices, schools, as that targeted approach as well. So we meet as many of those carers in those communities as we can.
Is there a timescale put in place for that to be implemented? Are you working over an 18-month plan or a 12-month plan?
I'll just come in on that. I think so Ashfield and Mansfield are in the top 10% for deprivation nationally and have been for a long time. So there is, as Anna's described, obviously, it's about a broad range of work from a public health perspective in terms of looking at deprivation and supporting that in an area. That's kind of everything that a council and partners should be supporting with and working hand in hand with people in those areas, with groups in those areas. In terms of the caring side, that's the strategy here. We are recognising the higher number of carers and therefore targeting activity even more so into those areas and just being very carer aware and thinking family when we're doing that work. But in terms of, I don't think we'd expect to suddenly see lots less carers in those areas in 18 months.
Councillor Smith.
Thank you, Chairman. Just moving on to technology, if I may, paragraph 38 and 39. One of the best visits I went on as leader of the council was to the test site of the technology hub. I think it is absolutely fantastic what reassurance that offers both the carers but the people who are being looked after. So if you're caring for a family member who lives more than 10 or 15 minutes away, it can be quite worrying if they haven't taken their medication or if they fall over. And the fact that we can have technology so I can sit at home and know that the person I'm caring for has taken their medication and hasn't fallen over in the night or fell out of bed is tremendous. And I think all credit to you and everybody who was part of rolling that out. It says, paragraph 39 says that we have about 36% of carers are using that technology. Is there any way of increasing that? What's the plan? And picking up on the point Councillor Wright just said, you know, do we have timescales of when we expect to be at 40%, 50%, 60%? Because we're not in this job to save money in care, but it does also help the budget a little bit as well for Councillor Anson's sleep at night. So just wondering when we can get to 100%, please.
Yes, so to add to those stats, people that draw on care and support that are having their care and support in the community, over 50% of those people have some sort of technology as part of their care and support, which is brilliant. We've worked really hard over the last few years to build that, and we've got lots of stats that show how that has helped so many more people stay independent in their own home and not go into residential care, for example, too early. And also has shown it's reduced carer stress and anxiety, because if you've got something alerting you that your loved one is leaving the house or has fallen over, you know you're going to get that signal. You don't have to be going round to dad's every single night, for example. So that's a really important part of the picture, and you can see that 36% of carers who've had a carers assessment have also got some sort of tech. So over this year, 25-26, we want to move from 50% to 60% is our ambition in our tech strategy of people that draw on care and support in the community to have some sort of tech as part of their support. I'm not sure we've got an exact stat on the number of carers, but we would expect it to correlate. But I'll take that back actually to our tech strategy just to check it out.
Councillor Cox.
Good morning. I want to go back to the Ashfield and Mansfield district because, well, I'm part of the Ashfield group, as it were. And you say that we've got the highest deprivation and we rank quite extremely high up in the national statistics. What do you think the factors are, the reasons for that, and what's the strategy for coping with that or dealing with that from a future perspective from this new strategy?
I'm from Kirkby and Ashfield originally as well. I think there's a massive answer. We know there's a lot of history with fantastic areas. There's a lot of history. For example, the whole mining background and jobs that went that did cause some deprivation, etc. That it's a massive answer in terms of why certain areas have higher levels of deprivation than others. But what we do know is that the likelihood of needing adult social care and support increases both with age and deprivation levels. We see that correlation in all of our stats. So that's why we should see more carers in Ashfield and Mansfield, and it's really good that we have more self-reported carers in those areas, because it means then we can make sure that we're getting information and advice to those people. So I think it's a much bigger conversation, public health conversation, about up and down the country why some areas are more deprived than others, and that could be a bespoke session that might be useful to look at a whole range of things. But yeah, I just wanted to make that correlation to it's actually positive that we've got more self-reported carers.
Thank you. It's, my concern, I suppose, understanding is that there are other mining areas across the UK that went through the same, dramas that we went through in our region, and I just don't understand why we are so far up that particular chain. And it's, to get an understanding and trying to identify what the problems are so that we could perhaps address them as a council, at council level as well. Is it something that we as a council have done in the past or not done? So it's just about trying to identify it so that we can support you guys across the board to perhaps bring those numbers down, so that that Ashfield and Mansfield are not so far up that league table, as it were, and that we correlate with the rest of the county. So, it's just trying to understand that. If we can arrange something, Chair, that we can look at this, for the Ashfield and Mansfield area, then, I welcome it. So thank you.
Noted. Thank you, Councillor Cox. Councillor Rich.
Thank you. So I've got a bit of a random question. So forget about the family hubs for a moment, right? Have you ever reached out to that organisations or charities itself to actually address anything that might need care issues at all? And also, do you mind mentioning at least an organisation or a charity that you've actually worked with in that regards? Thank you.
Lots to say on that as well. I think as part of our carer strategy, again, we're trying to work really widely across Nottinghamshire with as many public, private, voluntary and charity organisations as we can from that identification perspective, but also probably two other reasons. Firstly, to look at where we can leverage opportunities. So I've used the example of some of our local gyms had given some 3-month free passes, for example. So we might have lots of local organisations that would want to support people, including carers, with some things to support their mental and physical health. But then the other reason is to reach out for particular expertise, for example. So I mentioned Hetties earlier, which is an organisation that Hetties supports people that have got that supporting somebody with substance misuse in the household, for example. So we are reaching out to a range of organisations. We're looking at veterans, for example. So we'd be talking with charities involved with veterans. Dementia is a huge theme in terms of caring, dementia and Alzheimer's. So again, working with charities, Alzheimer's Society, etc. So we do reach out in terms of specialist networks and specialist expertise and add information and advice, and make sure that we are creating the right networks that are bespoke to particular groups of carers.
Councillor Girling.
Yeah, thank you, Chairman. Last question, you'll be glad to hear. I was interested to hear about this £30,000 carer support fund, which, if I heard you right, you said it's now come to a close. And it was basically because of COVID. You stole it from the COVID pot. But anyway, brilliant. Well done for doing that. So my question really is was that how that was spent, evaluated, to see that it was worthwhile spent? And if it was, and it's been proven that it has been spent well and it did a lot of good, so what are we putting in place to replace it, basically? Are we putting a business case together to say, look, that £30,000 done all this good? I mean, and if you look at it, £30,000 between 80,000 people is not a great deal of money, is it? So if it's supporting that. So I'd just be interested to see, have we done that? If so, and we think it was worthwhile, what we're doing to put in place to make it so that that money, because that pot is filled, if you like.
Yeah, so the fund itself was managed by our Carers Hub. So in conversation with the Carers Hub, we know that people have really valued this. The self-reported feedback has been really positive from people, and we can see what people have been spending the fund on. We are just in the process now of pulling together that evaluation report, but all the anecdotal, feedback has been, it's been a really positive fund. As soon as I get that evaluation report, we'll be pulling together that business plan. But obviously, starting to look at next year's financial planning and things like that. So we'll look at that as part of that bigger round, and we'll take that learning going forwards.
So it's ready for you then, Chairman. So when they've done that report or business plan, if you like, is it going to come to us to be scrutinised to see if we will endorse it as a group to say yes or no or whatever?
Yes, certainly, we can get that circulated, not a problem. Yeah, can you make it out?
I didn't circulate it. I mean, come to the committee, to this committee, so we can discuss it and say, because we as a committee can put recommendations into the cabinet, because I'm assuming it's a cabinet decision rather than a full council decision. So I just think it'd be worthwhile as seeing it first, and maybe we can do recommendations to improve it or whatever, to give it a good chance of actually being successful. So
Yeah, I mean, we can make it an agenda item when that comes up, and obviously bring it to committee or a report, whatever. Yeah, but we can certainly look at that, councillor.
Thanks, Chairman. Thank you.
No problem. Yes, certainly.
Thank you. Guy Bundickler, Interim Director of Adult Social Care, and apologies I was late a couple of minutes. I just wanted to add though that it wouldn't be a case of waiting for the evaluation to see whether a carer was in need and needed some financial contribution. So there are other avenues that we can use. So the carer is assessed as in need. And the example I give, which is one that comes up quite regularly, is sometimes carers have to do a lot of washing. Quite often the washing machine breaks down. And actually, if they needed a washing machine, then we would help them with that in order to be able to carry on with their caring responsibilities and things they do. So it wouldn't be a case of waiting for an evaluation to be able to do that. They can have that through a direct payment.
Okay. Sorry, I have a question. Just get back. So, item number 17. Updates have been carried out to internal processes. So we've obviously heard a lot from the presentation. We were able to see the results of, or let's say the fruit of the changes that have been made. But could you just update the committee on, when you specifically mention internal processes, what processes have specifically been updated internally?
Hello, it's Emma Shand. Good morning. Service Director for Community Social Work and Occupational Therapy. So I can speak a bit in terms of our processes for the assessments and reviews for carers that we undertake as part of our wider work working with people who require care and support. So over the last year, we've been going through a reorganisation of our service and looking at our processes and thinking about how we can work more in terms of a place-based and neighbourhood approach. So we've redesigned our teams to work at place level, which I think would help in terms of, I think it was Councillor Cox asking some of those questions about Ashfield and Mansfield, and thinking about some of the ways that we can support those communities more effectively in terms of that response. So in terms of assessments for people who are carers, we have the Carers Hub, and people can access assessments that way, and also advice, support and guidance. But also when our social workers and occupational therapists are going out to see people, undertake their assessment work, or reablement and prevention work as well, they will always be thinking about that family approach. So the person with the care and support needs, the person who's looking after that, if there's carers, in terms of what their support needs are, and actually their rights. So unpaid carers have the same rights as people who are cared for under the Care Act. So we have a responsibility to assess their needs, to support them and to review those needs as well. So in terms of our internal processes, we've redesigned our service, and we've really focused actually put increased resources in terms of staff and resource in those areas that have higher levels of deprivation and need, so that we can respond to those communities more quickly and reduce those waiting times in those areas. And in terms of our internal computer systems that we use in order to undertake those assessments, we've streamlined our processes to make it easier for staff to undertake those assessments and reviews quicker. The other thing that will be coming is also we're looking at other digital approaches to do that, to actually free up staff time even more, so you spend less time in front of their computer and more time actually with people and in communities doing that face-to-face work. So we can talk about that in another time, or bring that into other answers if needs be. Thank you.
Thank you. Councillor Butler.
Thank you very briefly. On paragraph 40, looking ahead for 2025-26, and you've got a plan and the priorities, which is good to see. So you know where you're aiming for and what we're trying to achieve, and you've achieved so much so far. That's good. What do you think are the biggest challenges to actually achieving what we're trying to achieve? I expect there's probably quite a few, but are there any particular big issues that, say, in a year's time, you might, hopefully this doesn't happen, you might come back and say, well, we were going to do this, to do that, but we didn't because of. And do you think there's anything that stands out in particular?
I think I'd probably take the opportunity to go back to that big headline from my perspective, which is enabling people to recognise that they're a carer as early as they can in their caring journey is probably the number one aim. So your question about what's the biggest challenge, what might get in the way, I think it is having the resource to be able to work across our fantastic, massive county, to be able to do as much appropriate profile raising work as we can. And I think it's not just as simple as shouting about we need to identify carers. It's being able to roll that support out well. So working in a really targeted way, as we've described, with GPs, with schools, with a whole range of organisations, with employers, working with organisations that might want to gift something, a free swimming session per week for a month makes a massive difference. I've got a quote in front of me of somebody that said, I'm paraphrasing slightly, but me being able to go to my swimming pool once a week makes me just feel so good mentally and physically, and it's those small things. So building, I think it's keeping the momentum up and building gradually and really well on all of those levels. So making sure when we're having conversations with a carer, we do it really well and we do it in that think family way, and then working in their local area with opportunities and enabling them to look after themselves is really important. And then looking at what can we do through our networks to pull in for free or cheaply for people to access is really important. And then thinking about all of our employers in all shapes and sizes across the county to think carers is really important. So keeping that momentum and building that togetherness really well.
Just adding to that, are you working with, or is there a scope to improve work with perhaps our communications teams departments? Are they on board with this? Are they supporting and working with you?
They definitely are, yeah.
Any further questions? Councillor Cox?
So we've heard about all the challenges you face. And obviously and that's what we're here for. But what's your most significant achievement since the strategy's been implemented? Let's finish on a positive.
I think the stories of difference from carers that show us what difference this is making to their lives. We've got brilliant stats that are showing us that we have been able to support people that did feel on the edge of a family breakdown in terms of coping, and that's been avoided, which is brilliant for that family. But hearing individual stories, so I'll read one if that's okay. I have access yoga sessions on a Monday through Gedling Borough Council at the Carlton Forum Leisure Centre. These have helped me keep supple and flexible. Really useful for me in terms of any lifting I do in my carer role.
Thank you very much.
Councillor Gurley.
Just a way of maybe helping support you getting the information out there. The council's very good at, when we have roadworks, we get a roadworks bulletin, which is a PDF, and as a council, it's dead easy. You screenshot it and then put it on your social media. If you get into the routine of when you do your posters, that you send it out to all the councillors, I'm more than happy to screenshot it and put it on. So that's another way of getting the information out there, really. So maybe just think about doing that.
Thank you. We really appreciate that.
Councillor Wright.
Do businesses reach out to you with freebies for carers and siblings and things like that, or is it something that you have to seek?
I think we're doing more seeking. So anyone that might have networks that can help with that seeking.
That was my
gratefully
next
receive.
question. Would you like us as councillors to go out in our communities and get some relationships built up?
Yes, please.
Okay,
Be
well then I think
fantastic.
all of us here can rise to that challenge then, can't we?
Thank you.
All right, thank you, everybody. I'm aware that we're an hour in and we've had a good amount of questions. So, Martin, is there anything further that you need to add?
Yeah, just three things. I think with what Councillor Cox was saying, I think we probably need to have a bit more of a conversation about that to find out what would be the most appropriate way of getting that, because that is, as Katie identified, that is a massive topic. So I think we need to talk about that a little bit more. Just two other items. In a format to be agreed, I think the members would like to be involved with what comes after the carer support fund and what that looks like. So we can obviously have some conversations with officers about that and see how members can best be involved. And that work is carried out to look how members can be supported to support and identify carers in their local areas. So see what we can do about that as well.
Thank you, Martin. Okay, I'll note that the recommendations have been moved and seconded. And can we take a vote with a show of hands, please? Okay. Oh dear. Yep. Okay. All right, everybody. Okay. Item 5 on the agenda is the occupational therapy service delivery, and I would like to ask Councillor Barry Answer to introduce the report, please.
Yes, it's that was a lot of children's services as well, which isn't my remit, but I do thank everybody for the questions and their input into those queries, and our colleagues here for giving sufficient answers. But on this item is to provide information to delivery and performance of our new county-wide occupational therapy service. A therapy first ethos is being embedded to support better outcomes of Nottinghamshire residents who require adult social care assistance. Occupational therapy helps to live your best life at home and at work, and therefore and everywhere else. It's about being able to do things that you want and must do. That could mean helping you overcome challenges, learning at school, going to work, playing sports, or simply doing the dishes. Everything is focused on your well-being and your ability to participate in activities, and I think that's important for every household and every person. Occupational therapists work in several different areas of practice and support people who are or have experienced mental health conditions, physical or learning abilities. And then in the report it lists a number of items there. The redesign of a new occupational therapy service implemented from the 1st of June This is the aims of the social service for occupational as part of the local account and following engagement with people drawing on care and support and carers and staff were as follows. And I think, the better outcomes for people and carers, well, we all want that. People support in their own homes and communities, consistency and experience and approach to people and carers, and the use of cost and effective life affirming community resources and digital solutions to promote independence. And I think, going on for, I think this is a very important aspect of this. It's number 20, and it's occupational therapy data capture includes waiting times for allocation of a worker, waiting time for the initial conversation, number of assessments completed by the worker, role and types of interventions, which varies but can include advice, minor adaptations and or major adaptations, and quality of assurance. The most important thing out of that paragraph is the time factor. When someone needs some help and some support, we need to be as quickly as possible as we can to support that and to implement those actions that's required. And I'm sure that my colleague down here will have a little bit more to say about that.
Yes, hello, it's Emma Shand. So I'm really delighted, really, to be able to come to bring this item to committee today. It was a request from previous administration to talk about occupational therapy, the difference it makes in people's lives, and the impact in terms of our reorganisation of services, in terms of how we've invested in occupational therapy for the local authority and for the residents of Nottinghamshire. So the key things that we understand in terms of wanted to focus on today was really thinking about that access to occupational therapy. So how do people access OTs, occupational therapists, in Nottinghamshire? Their waiting times in terms of how long are they likely to wait for an assessment and also for an intervention. And then some of the outcomes and the difference that makes. So the differences that makes to people's lives, to people requiring care and support, to carers, and also to local communities. And so the report, we hope, demonstrates that and gives that information for your consideration. We do have a presentation to talk a bit more about OT, so we'd like to share that, if we may. And in order to take us through the presentation, I'm going to introduce my colleague, Maria Ballantyne, who's our Head of Service for Occupational Therapists, and is an OT. I'm a social worker, so she's much more of an expert in this area.
Okay, we're just, Martin's just loading the report.
Thanks, Martin.
Sorry, the presentation.
Hopefully brings to life a bit more about the impact of OT. And while we're waiting, perhaps it would be a good opportunity just to say that in the local authority we employ occupational therapists, and they work to our Care Act legislation. The NHS also employ occupational therapists. There's quite a differentiation between the roles and responsibilities of health OTs and social care OTs, and then a very wide range of activities in terms of occupational therapy for adult social care. And they also work with children as well, so we have a children's occupational therapist service too. In terms of our setup, in terms of the council, we have so all new people coming through our front door, customer services, or for hospital discharges, we would expect that they would see an occupational therapist, whether it's through our maximising independence service, who are there to promote enablement and re-ablement, to really support people to learn new skills or to regain skills and independence, or if following a hospital discharge, whether that's from acute hospitals such as King's Mill or in what's now Nottingham University's Trust, and others perhaps after an injury or an illness, but also for those who are being discharged from mental health hospital as well. So we'd expect that they would also have occupational therapy support to help them to regain their independence skills and quality of life. Our occupational therapists work with a wide range of people with varying presenting needs. That could be a physical disability, could be a learning disability. And we work very closely with our health colleagues in terms of learning disability OT support, or could be someone who's had a fall or a fracture or age-related conditions. How are we doing? Would you like us to make us, Maria, to make us? Oh, there we go.
There we go.
Okay, when you're ready then, Maria. Thank you.
Okay, good morning, colleagues. My name is Maria Ballantyne. I'm a head of service for occupational therapists and being an occupational therapist myself of many years. I just wanted to start with a very brief overview. I won't read through the whole slide, but just to put into context what occupational therapy actually is. So we look at occupation. So by that, we mean the activities that we do for people to live as independently as possible within their own lives, within their own routines. So it's things like how we all get out of bed of a morning, how do we swing our legs out of bed, how do we stand, how do we walk to the bathroom, how do we pick up a toothbrush. All of that is to do with activity. It's about function. It's about what we have to do to be independent. So bearing that in mind, we also look at people, as Emma has just pointed out, people who have had an effect to that way of living. So, for example, we work with people who suffer with or diagnosed with multiple sclerosis. We work with people who are elderly, who have fallen, who have fractured a hip or a shoulder, etc. What we actually do is we go in and we work with these people to say, okay, what is it that you can do? What is it that your routines are? What is it that you would like to do? So I'll share an example here of a beautiful example of a lady that we were involved with from an occupational therapy point of view. She'd fallen, she wasn't eating very well, and she was very, very low in mood. So rather than going in and focusing on, actually, you've fallen, you can't do the things that you used to do, how can we support you? Now, what this particular lady wanted to do, she had a donkey at the bottom of her garden. So we said, okay, what would you like to do about the donkey? She said, well, what I want more than anything is to be able to get myself down the end of the garden and give the donkey a carrot. Now, it sounds a little bit strange because we were thinking, okay, you're struggling to get dressed, you're struggling to clean your teeth, etc., etc. But what we did is, okay, we'll work with you. Let's start doing some activities so we can get you down the garden. So over a period of about 3 weeks, we went in to see the lady, and every time we went in, we did a little bit of what we call activity analysis, and we walked her down the garden bit by bit, let her prepare the carrots with some support, and over a period of 3 weeks, we were able to support the lady, so walk behind her to get to the bottom of the garden to give the donkey a carrot. So because she was seeing actually how well she was doing, her ability to do and care for herself increased as well, so her mood lifted. By the end of our intervention, we would go to the property and she was already at the bottom of the garden, well fed, well kempt, really well, bright in her mood, etc. So actually what we do is we think outside the box. So so I just wanted to share that example because actually from that lady's point of view, we do have a lovely photograph in our archives of her giving the donkey a carrot. But actually for me, it's not what we want, it's about what the individual wants, and that's what we do as occupational therapists. Can we go to the next slide, please? Okay, so again, I won't read through all of the slides, but in terms of occupational therapists, we can do something that's really, really what we think might be quite small. So it's about talking to people about, actually, you can do this. So information, advice and guidance, or it could be something as big as large as building an extension for somebody who has multiple sclerosis, lives in a house, isn't able to access the upstairs bathroom. So actually what we would go in and say, what is it that you want to achieve? And we would look at actually how can we make that happen. So we would work with our local housing authorities, and we would going and make recommendations for adaptations to properties. We also use tech, so technology-enabled care. So that's things like a falls detector, for example, or a medication reminder, because obviously we work with people in the communities who have memory issues. Actually, what they don't want is they don't want people to go in their home. So we work with them and say, actually, let's use and let's familiarise you with this piece of technology that will be able to support you to remind you. So the interventions are very wide and they're very varied. Next slide, please. Okay, so in terms of occupational therapy, one of our main objectives is to make sure that we work with our communities to prevent, reduce and delay the need for paid for statutory services as far as possible, but also to work with people to prevent crisis intervention. So what we see is people, for example, are diagnosed with multiple sclerosis, and they when we talk with them initially, people will say, actually, I'm fine, I don't need any support. And what we do try to say to people is, please let us know before you come to a crisis. Let's keep the conversation going, because actually if you come to us in a crisis, we can't do something within 12, 24 hours. Please come and talk to us, and actually we'll support you with that. That's one of the things that we're actually working on at the moment is okay, how can we make sure that we can reduce any crisis intervention, because we don't want to be making urgent decisions at that point. So another way in which we work with people is about supporting their well-being. So the example I've just given you in terms of the carrot and the donkey, actually the lady's life and her well-being was absolutely phenomenal following that. And actually what we also work with are people who linking in with Katie and Anna's work, is we work with children who are transitioning from children's to adult services, and actually how we can prepare those people and their parent carers so that they understand the transition process, and actually what can we support people with to make sure that they maintain their independence, or if they're struggling with independence, what is it that we can do to support them to maintain and build that independence. And actually what we also do is we listen to feedback from our communities. So what we want to make sure is actually what's working well, what's not working so well, and that's the information that we welcome, because actually if we don't know what we're not doing quite right, we need to make sure that we put that right for communities. One of the other big things, as Emma has just mentioned, is that we have been through a recent redesign. So we now have a county-wide occupational therapy service, which I oversee with team manager colleagues who are also occupational therapists. So we do have 82 members of staff, occupational therapists who are based within our district occupational therapy teams, and also based in our maximising independence service as well. So what we do is we all come together to make sure that we're maintaining a consistent practice across the geography and the demographic for Nottinghamshire. And obviously we make sure that we have a streamlined message and it's consistent for people. So what someone would expect to have as a service in Bassetlaw, they would have in Mansfield, Ashfield and in the south of the county as well. Next slide, please, Martin. Okay, so in terms of waiting times, we are currently in the process of adapting a dashboard that we have, which signifies the waiting times that we have for assessment. Now, in terms of when people come into our service, we triage that information that we have coming through, and if someone is a priority, we will get out to see them within 24, 48 hours. We obviously make contact with them via telephone straight away, and we say, actually, we will be out to see you. Now, for those people who go onto our waiting list, we have just introduced a process whereby We send out our waiting well information, which gives them a lot of information, advice and guidance on where they can seek support for themselves whilst they wait. And we send out a letter with that information so that they can, with our duty telephone numbers, and then obviously if the situation changes, we encourage them to come back so we're avoiding that crisis intervention. The other thing that we do now do in terms of our waiting times is for those people who are sat on the waiting list, which has reduced since the implementation of the service in June. But what we do is we call people on that waiting list and we say, we're just checking in. How are you? Do you need anything? Just to let you know that you have now been allocated to a worker. So we're doing the best we can to make sure that people feel involved in their waiting process. In terms of managing performance, what we have also introduced is a weekly sit rep. So I know as a head of service, actually, how many people that we have in works in terms of workers, members of staff, how many vacancies that we have. And actually, I'm proud to say that we only have, across the whole of the county, 2 occupational therapy vacancies at the moment, because we have been very successful in our latest round of recruitment, because actually what people are seeing now is a streamlined occupational therapy service, so I'm very proud with that. But in terms of the sit rep, what I'm interested in is actually how many referrals, new referrals, are coming into the department, and actually how many cases are we allocating out. So how does that impact on the waiting times for people? So we've just started that in the last couple of weeks, and what we are seeing is that the waiting lists are going down, and actually when we're calling people, some people are saying, actually, thank you so much for the waiting well information. I've been able to go off and make my own decisions or self-fund a piece of equipment, or could you give me some advice? So that's really positive. Next slide, please. Okay, I won't go through the stats too much, but this is the information that we currently hold on our dashboard. So it's about the kind of information or interventions that we have. So mainly we do provide equipment and adaptations. What we're trying to do is, when you look at the bottom of the left-hand graph, what we're trying to do is increase our use of tech, increase our use of doing more enablement from the district point of view, because actually, if people need equipment, that's fine, but that doesn't solve the problem for people. What we need to do is work with them. And we also have had an increase in the number of conversations that we have with people. And in terms of the waiting times for allocation, what we have done since June is we've reduced that from 28 to 27 days. So we're really proud of that. And obviously what we're doing as a county-wide team is looking to make sure that we can reduce that further still. Can we go to the next slide, please? Okay, so how we will monitor our performance. So we have just developed a quality assurance form, a feedback form. So what we will do is at the end of our intervention, we send a closure letter to people, and we enclose a feedback form. And what we're saying is, or asking, did the worker listen and focus on what mattered to you? Because actually it's your outcome, it's not our outcome. We will do the best we can to support you, but actually did they listen to what you wanted? And actually what worked really well, what didn't work quite so well, so that actually we can build on what our communities are saying to us. Now, from this, we've just introduced this, but what we will do is on a 6-monthly basis, we will draw all of that information together, and we will be able to report on our performance. However, what we will do is if we have something that needs work, we will address that immediately. So we'll contact the individual and say, actually, can you tell us what happened? What could we have done better? What would your view be? What we will also like to do is invite those people to talk to the team, so actually they can see what the impact of that not working quite so well has had. Okay. So I just added here a couple of stories of difference, and one of the bottom one I'd like to go through really is just one of the adaptations that we supported with around a level access shower for a lady who had multiple sclerosis, so she wasn't able to access her bathing adaptations, but we had a community care officer, Hazel, who went to see her and really listened and said, actually, what is it that you want to do? And obviously from the lady's perspective, she said, actually, I do have a progressive condition. What I want to be able to do is to be able to bathe. So what we did do is we went in, we looked at the adaptation, but actually what we did, we focused on the future. So we didn't have to go in again and provide more equipment or more adaptations. What we did was we built an adaptation that would last her for now and as her disease progressed. And as you can see, she was so thrilled that actually her life was so much easier as a result of the intervention. Thank you. Thank you very much.
Thank you for that. Anybody, anything else to add? Okay, thank you. In that case, we'll move on and we'll move the recommendation as detailed in the report. And could I have a seconder, please?
I'll second it for you.
Thank you very much. Okay, we'll now open the floor for debate. So if any questions, all right, okay. Councillor Rich, I think.
Thank you, Chair. So what's the cost and evidence of... Oh, no, I'm starting. Yeah, what's the cost and evidence opportunity of being explored and redesign of the service?
Sorry, would you mind just repeating that one more time,
Yeah,
Councillor
sorry.
Rich? Apologies.
Okay. So what's the cost and avoidance of opportunity of being exploited in the redesign of the service?
That's an excellent question, thank you. So as well as having talked about the more qualitative outcomes of occupational therapy and the impact on people's lives, a key strategy for us is by getting in sooner, supporting people to be as independent as possible, is actually it reduces our spend, as in terms of so we're trying to look at every which way we can do to manage our budgets effectively and to make best use of the resources we've got. So a key part of that is we haven't increased our occupational therapy workforce, but we've redesigned it so that we've made it more effective and streamlined so that the staff are able to focus on occupational therapy solely. Previously, they were also undertaking some sort of more generic social work and social care tasks, really. So we really focused our resource, our qualified staff and our experienced community care officers who work alongside occupational therapists who are non-qualified but skilled members of staff to really focus on the impact of occupational therapy. Through the use of tech-enabled care, through the use of adaptations, but also use of equipment has really helped us to thinking about more effectively as part of our culture change, rather than using a paid service, so paying carers to go and see somebody to go to the house and do something for them. How can we support them to be as independent as possible and make sure they've got the right bit of kit, really? It means they won't need a paid service. So what we want to do by using occupational therapy as an intervention and approach is to support people to be independent, but the win-win for us is also then that we've got people who are living more fulfilled lives, but we don't need to spend so much on them. And we delay any spend in the future. So in terms of our redesign was around particularly around practice, around the consistency of our social work and occupational therapy practice and outcomes for people. The feedback we'd had was that people in different parts of the county and also with different presenting needs were having a different experience and outcomes from the service. So by making that a consistent approach, we're hoping that we'll be able to reduce that. People can expect a similar level of service and of excellent service. We're also now thinking about, as our budget pressures for next year, is actually how can we use occupational therapy even more and invest in that in terms of thinking about the experience of staff, the training needs they might have, what sort of equipment do we need to be supporting people to access, and where people can afford that, where we encourage them to do that themselves, and also how we think more in terms of the world of digital and tech is kind of moving ahead all of the time, so it brings more opportunities. So in terms of there's an example of a small cost avoidance example in the report around preparing for adulthood. that showed that actually through working with a young person and their family, while they were still being supported by children and family service before they reached 18, we were able to mitigate a significant cost to adult social care budget. So that's another key element of the work that we're doing there. I don't know if you want to come in anything specific there, Maria, or add anything more there.
No, I don't think so.
Okay.
Thank you.
Well, anyone else? Do I hope that answers your question?
Thank you.
Thank you.
Councillor Gurley.
Yeah, thank you. Before I ask the question, I think that donkey will also be very happy, won't it? Getting them carrots, waiting for it to get down that garden. Actually, coincidentally, I got a phone call yesterday about from a daughter whose mother, whose mobility has really gone downhill, wants to have a bathroom adapted so that she can actually get in, or she can't get into the bath without standing on a stool, which is dangerous and she shouldn't be doing it. And I've been told the waiting list for that adaptation is quite substantial. It's about a year at the minute because of funding. And I wonder what are we looking at doing to try and improve that because obviously, you know, a year is not, if you can't get in a bath, a year is not an acceptable amount of time, is it? Really. And the other thing which I've not seen within this, and you'll forgive me because I spent years being the Armed Forces champion for this county council, is what else has been done in terms for veterans, because we know that veterans, if you ask them, are they all right? Yeah, I'm all right. And quite clearly they're not. They'll get out of bed like I get out of bed in a lot of pain, and it takes a while for my body to start working before I can stand up. And so, but I also know that if you include veterans in a lot of things, there's additional funding available, but it's not covered within this report, and I think it might have helped if that sort of thing would so if you could just sort of tell me what you're doing in terms of that, that'd be brilliant. Thank you.
Thank you for the question. I'm happy to talk about this. Okay, so in terms of the waiting list for our own occupational therapists is around 2 months at the moment. So what happens is that our occupational therapists go to visit people on the waiting list, establish what their needs are, and obviously identify if any adaptations are needed. Our work is to very specifically recommend to our local housing authorities what work is required. So what we do is we generate a report, we send that across to the local housing authority. A financial assessment is then undertaken to establish whether or not someone has a contribution towards the cost of care and support. Now it's at that point that we do look for charitable funding from the Royal British Legion, from CISWO for those people who've been minors in historically. So that's what we do in terms of accessing charitable funding if it's required. The wait list, the year that you're hearing about, happens when the recommendations go across to the local housing authority. So they have a pot of money, if you like, which is called the Disabled Facilities Grant. So they're allocated an amount of money on an annual basis from central government. And then what they have to do is they have to have a look at all of the work that's incoming in terms of those requiring disabled facilities grant funding. So that could be a shower adaptation, it could be ramped access to the front of the property, it could be an extension or bathing. So what they have to do is they have to work through actually who's the priority. So for example, if someone has motor neurone disease and the prognosis could be anything between 3 and 5 years, sometimes less, what they tend to do is you prioritise that work because obviously they need to have that done to support someone. Then what they have to do is allocate their money across the recommendations that all of our occupational therapists send through. That's where the weight is. So within all of that work, the cost of labour, the cost of materials has risen exponentially. So the money that our local housing authorities have is far less. It doesn't go as far as it used to do. So what we know is when we are doing our recommendations, and we know that we absolutely need to have an adaptation such as an extension, that will cost £80,000. So we have a £30,000 disabled facilities grant. That's the mandatory amount of money that people can have. And then, of course, we need to have a look for charitable funding, discretionary grants, and of course, all of that takes time. So what I would say is actually it's a case of our little bit, our occupational therapy bit, we can get to see people within a couple of months. The adaptation sits with the local housing authority, and that's where the length of time for the waiting list is.
Can I just come in there? I was just going to say, so I just want to say that, so we've been doing some, there is some focus work with district and borough councils to think about how can we support in any way to help, not in any way because we don't have the money to provide for the adaptations, but how can we facilitate conversations, particularly between different district and borough councils and not, if there's any way of pooling budgets or any other creative ways. And our principal occupational therapist spent quite a lot of time doing that in terms of working with district and borough councils around that. I guess the only key thing for me was it's awful that someone would have to wait 12 months at least to have be able to access their bathroom. The worrying thing for me was just if they're standing on a stall in the meantime, is perhaps we might need to, if we don't know about them, we would like to, because we'd like to, if there's anything we can do in the meantime to make that situation safer, we would want to intervene and provide perhaps an alternative or think about some problem solving and some support in that scenario. So perhaps if you would ask their permission to share details, we'd be really grateful for that. Thank you.
And can I come back in at that point? Just to, yes, I'm sorry I left that bit out. Of course, in terms of the recommendations, we will always, as occupational therapists, go in and offer a temporary piece of equipment or a temporary way of being able to meet your own self-care needs or access needs. So we would always look to provide equipment or such. So you're absolutely right, to stand on a stool it's not appropriate, but we do have smaller pieces of equipment which are far safer, and we would go in and we would support people to make sure that they can access their current facilities the best way that they can until such time as we can go out to work with the adaptations.
That's brilliant, thank you. So from my perspective then, as a councillor, we're doing our bit relatively quickly. I understand that £30,000 is not a great deal of money and things like that, but there's something inherently wrong with the system if it's taking that time. So I just want to know, like, is that something that we can do as a council to try and come up with a better system? Because if the system isn't working, then it needs changing. And just to say, oh, that's the system and that's why it takes so long, it is not acceptable when you're having to climb on a stool to get into a bath. You see what I mean? So I'm not calling anybody. I'm just saying that we've got a system that isn't working. What are we going to do about it?
Just come in on that, because actually some councils have looked at this in different ways. One of the things that can be done can be to look at whether somebody wants to commission the adaptation themselves, so they know what the pot of money is, and then it doesn't rely on us waiting for us to do the work, either in the districts to do that work. So people can have that option if they want to. I don't know whether that happens here or not. It doesn't happen. It does happen. So some people will choose to do that. That would mean that they could do that much quicker themselves if they know who they can get to do the work. I'd encourage that to happen more, so that then releases some of the other opportunity for.
Sorry, can we move on? Oh. Sure. Councillor Gowland.
Thank you. Sort of following on, so you've talked about adaptations to buildings, and of course, I guess there aren't enough builders, which is the problem, isn't it? But smaller adaptations, stools, cups, things like this, I think you provide as well. Where do they come in the budget? How does that work? Are people presumably pay for them as well? If they're paying for them, do you help them get them, you know, literally obtain them? And if they're not paying for them, have you got the budget? Where does the budget come from?
So we have a joint budget across city and county for integrated community equipment loan service, ISILs. Anna, you might just want to pull up the stats for me if that's okay, so we could give you an idea of the size of that. I think we've had something like 140,000 people have had temporary equipment loans. Need to check on the period for that. It's the last year, I think, isn't it? In the last year, which just shows how extensive that prevention offer is, and how important. And I'm pulling the figures from the top of my head. We can clarify. It's something like between 80 to 90% of that equipment gets recycled and reused as well, which is brilliant. But a whole range of things, and that might be walking aids, it might be particular types of mattresses to help people, all sorts of things in the home. So really good that we're doing that in a joined up way. So we've got a specialist service that can get things out to people same day or next day if it's really urgent, or it can be a bit longer if it's less urgent. But the variety of equipment that helps people to stay independent in their own homes is extensive and does work really well.
Councillor, sorry, Councillor Garland.
I mean, that's amazing, and it's great that you say to be such a high recycling rate. I'm just still worrying about, not worrying, but wondering about the budget limitations, because obviously with more digital stuff, I guess the prices just go up.
I think it is fair to say that adult social care up and down the country is really, really stretched. And therefore, us focusing on prevention as much as we can rather than people getting to crisis is so important in that. But yeah, we are constantly trying to make the best decisions that we can with the resources that we've got.
Councillor Butler.
Thank you. This sort of leads on from the other two questions in actual fact, and also paragraph 22, the relationship with the districts and the boroughs. On your presentation, we saw a very quick look at your dashboard. I didn't really see it that closely. What I could see, there was a graph showing the different boroughs and the different figures against those boroughs, and they, even at a glance, there seemed to be quite a big difference between them. Now, I'm sure you'll explain why that is, but I'm guessing, is it partly to do again with things like demographics and demand and such like in the different districts? So you have your certain areas which are more challenging than others. You're nodding, so I've answered my own question there. So, thank you for that. But and you also mentioned the funding that the boroughs and the districts get for home adaptations. That's, I think you mentioned it, but just to confirm, is that central government funding that comes through? And is it a fixed amount per district, or is it worked out on what a perceived demand or need will be in the districts?
Okay, thank you for the question. So in terms of the, if you like, the allowance that each local housing authority will receive, it's based on the amount of social housing that they have in their district. So it's pro rata in effect. So for example, Ashfield, Mansfield, they have high numbers of social housing. So obviously their grant, their reward is higher. In Rushcliffe, for example, they don't necessarily have any or as many social houses within their area. So what happens is that their mandatory awards are far less. So of course that ultimately affects our ability to, if you like, not necessarily to attract the funding, because all of the local housing authorities meet with ourselves on a monthly basis. So what we tend to do is actually, if there's any money in the system, and this is what we're trying to achieve, is how can we share for Nottinghamshire? How can we make sure that it's consistent and people have access to what adaptations that they need to support them to live as independently as possible?
That's really interesting, actually. But and I know this isn't anything we are doing or the council's doing, but it's the system. But that surely means that in districts or boroughs where where their social housing figures aren't as high as others, then their residents who are not in social housing but need the service, they are. I hate to use the word being disadvantaged, but they're being disadvantaged, or am I being too simplistic here?
It is far more complex than you would think. Yeah. So basically, we have a mandatory award, which is the 30,000. Then we have discretionary monies. So the mandatory award is available for people to access. It's the discretionary monies that comes on top of that. That, for example, those people with less social housing will have. So they still have access to the mandatory award, but it's just the top up that it's complicated. Yes. And just on the theme of housing, what we're also doing is we now have an occupational therapist who is working with our strategic commissioning colleagues, so working with our architects just to make sure that housing coming online in the future for supported living, for example, will need less, if any, adaptation. So we're making sure that accommodation has turning circles for wheelchairs and the door widths, or the kitchens are accessible for people, so that we won't need to adapt as high in the future. The other thing that we are doing at the moment is we're working really closely with our Basset Law Housing Authority at the moment to have use of an occupational therapist who will go out to have a look at the stock that they have, just so that we can make adaptations so that more people can have access to the housing in that area. So obviously what we're doing is we're trialling it in Basset Law, and then hopefully we've got the evidence to be able to say, actually, this is working really well, and can we roll it out for the rest of the county?
Thank you. Can I be really brief following that up? Just in the paragraph you mentioned, and we hear this so very often, this word, the partnership working. I mean, generally speaking, how do you think it's going? Is it going pretty well, or is there still room for improvement? And I'm not asking to name or shame or anything like that, but you can understand where I'm coming from. I would imagine that there are perhaps differences in relationships, whatever, but how is it going on the whole?
We are actually really fortunate with our local housing authorities. Everyone is very willing to come and sit around the table. The issue that it's not an issue. Perhaps one of the concerns that we have is that we want to make sure that actually we have funding available for our communities, and that's the conversation which is a little bit more complicated, let's say. But having said that, people are very, very willing to say, actually, I will come to the table and I will discuss this. How can we make it better?
Councillor Smith.
Thank you. Just to pick up on a few points that colleagues have mentioned, and get to my question, if I may. The DFG grant that Councillor Butler was mentioning earlier was brought up in Cabinet yesterday, and under the previous Cabinet member, Councillor Wheeler, who did a fantastic job in lobbying government to amend the allocation of the DFG, because what happens is some districts underspend, and then Rushcliffe is underfunded anyway and doesn't get its allocation, which is the point you made, Councillor Wheeler, disadvantage for those areas. And I think the government have listened, and they've launched a review just this week, I believe. But Guy, correct me if I'm wrong, but that's a good thing. Just on housing, and it costs taxpayers a lot of money to put these adaptations in. I think if there are any silver linings to becoming a unitary authority, one of them will be that we will then become the housing authority, and we own a lot of land, and then we can go out and build our own houses that are already adapted, which will save the taxpayers money. We will own them a bit like council housing, and then you have that churn. And I think we should definitely be doing that and driving that forward in the unitary discussions. And Guy, at a senior level, we should be pushing for that, and your successor should as well. Just on the redesign, paragraph 14 and 15. Now, 14 A to D. Redesigns, really great. I'm sure our graphic design team had a nice fun drawing up a new logo and stuff, and we've redesigned the whole service. That's great. Everybody in this room will agree with the aims A to D. What I'd like to know is how we assessing the impact of that, and how are we measuring that, and can we add another recommendation, Chairman, to the report that in 6 months' time we bring back your impact assessment on the redesign, because it's all well and good doing a fancy redesign and putting loads of effort into it, but if the outcomes are poorer than the previous service, then what was the point? And we need to know that it's working. So can I add that as another recommendation, please? Thank you.
That's been noted, Councillor Smith, and will be added for a future committee meeting. Thank you.
Sorry, yeah, just in terms of impact and review and evaluation. So we've a set of measures in terms of our statutory duties that we've been measuring against more broadly in terms of redesign. So our waiting times, our number of assessments and reviews completed, the outcomes of those, also our safeguarding adults activity as well in terms of safeguarding inquiries that are undertaken by community social work and occupational therapy staff. So there's a number of our statutory measures that will be evidencing and tracking. Also in terms of impact, in terms of we expect it to be more effective use of staff time and use of budget. So that's another key element there as well. We are going to be going through, we implemented in June, we'll be starting our formal kind of review and evaluation in the new year. So that's starting point. So actually once we've got that initial evaluation, we're very happy to come and talk more about that. So we've got some key measures which have been set in place in terms of our statutory measures, those for our staff, also in terms of staff recruitment, retention, wellbeing also as well, and also through the big conversation that has already started in September in terms of listening to our adult withdrawing care and support carers and communities in terms of their experience of adult social care. That will also help us to shape those priorities going forward as well in terms of what people need and want from us. So I hope that answers that question.
Councillor Cox.
Thank you. It's not a question to you guys. Actually, it's something the guy said that I'd just pick up on, where you're saying that there's an option for an individual to do their own build. And is that a funded option if they know with a builder to do that build, or is that something that they got to self-fund?
So the assessment would be as described, and then we'd know what adaptation is needed. What can happen is people could request to have the money that is earmarked for that adaptation to then commission their own builders to do the work, essentially. So that is an option for people to be able to do.
Thank you.
And Councillor Rich.
Thank you, Chair. So I'm looking at the paperwork in the document itself, and there's nothing changed about young children translating to adulthood, so we might need that extra support. Can you be more clarify on that kind of thing, because I can't see anything on that regards. Thank you.
Yes, of course. I'm going to hand over to Maria, who can talk you through preparing for adulthood and occupational therapy.
Okay, so we are working more closely with our occupational therapy colleagues in the children's teams. So we are having now regular conversations with them, because obviously the funding for children's adaptations is different to funding for adult adaptations. What happens when someone is a child, then if they need adaptations, that work will be undertaken whilst they're in the children's team. However, if someone is older and they haven't yet had an adaptation, we are having a handover with our children's colleagues to say, actually, this work is coming through. Can we have the discussion? And then we will go out and do a joint visit with children's colleagues, and then we'll make our recommendations for the works as required. Basically, what we do find sometimes, of course, is that people grow, and if someone has had an adaptation, so for example, showering adaptation as a child, and obviously they've grown, it might be that we need to review that adaptations and make it fit for purpose for longer. However, what we do find is that when children transition through the process and they come into our adult services, we need to have a look at alternative accommodation for them. So what we need to do is identify what the alternative accommodation is, make sure that they can still use their current adaptation, identify new accommodation, and then adapt that property for them. So that's where the occupational therapist within the strategic housing team is going to be very, very useful and support us with making sure that actually accommodation coming online is more fit for purpose.
Can I just come in on that note as well, just to say, as a brief mention in paragraph 15, just to say that as actually part of our review of our demands and wanting to manage better and more effectively support young people coming through to adult services, we now have a dedicated occupational therapist in that team and that service who work very closely with children's also. So that helps us to do that more effectively.
All right, thank you, everybody. Thank you for your questions. Martin, is there any areas for further consideration?
It's just what Councillor Smith said earlier on, that we'll look to where our members can be involved in assessing the impact of the redesign in about 6 months' time.
Wonderful, thank you very much. Okie dokie. So we will, we've had the recommendations have been moved and seconded, and we will take a vote with a show of hands, please. Yeah. Thank you very much. Okay, moving on. So we will move on to item 6 on today's agenda, which is the Adult Social Care Performance, Finance and Risk Update. And I'm going to ask Councillor Barry Answer, the Cabinet Member for Adult and Social Care, to introduce the report, please. Councillor Answer.
This report covers a number of items, and particularly one to provide the committee with a summary of adult social care performance against priorities set out in the local account. 2, to provide the committee with a summary of adult social care, vital signs and key departmental risks. And 3, to provide the committee with a summary of adult social care financial position at period 3, 25-26. It's quite a lengthy report on all of these aspects, and particularly when you look at the report, there are assessments, and some parts are green, some parts are amber, some parts are red, as you can probably see within the report. But I'm going to ask the director, because it is a big report and a lot of really difficult items in there, so I'll ask Guy to move that forward, please.
Thank you. Okay, so as Councillor Answer says, the purpose is to update you on a number of things. For those who don't know about the local account is effectively what might be called as our business plan, which came out of a big conversation that we had with residents and people who use our services to inform our plans and the way that we want to work with people going forward. So in terms of the priorities that we've got, one is around wellbeing and independence, and you will have heard today already about the move to the redesign, which is to move teams into an all-age community team. This was in June. I would say, and this is something to consider when we're thinking about the report that comes down the line, is actually this is part of a journey. Health already work in an all-age way. We're supporting that work into going into an all-age approach in our community teams. But equally, we will further integrate with health as we go forward in the neighbourhood, so that we look at the population in the neighbourhood, think about what their needs are, and see how we wrap around support. Rather than it be about organisations, it will be about the team who are working together to support them. So that's part of the journey that we're on, really, and part of the changes that we need to make. Safeguarding performance remained very strong, as you can see in the report, with all indicators exceeding their targets. This is a critical thing for us. Safeguarding is one of our priorities, and making sure that people remain safe in the community. For the first time, actually, we're very proud of the fact that for people of working age adults, more people are living in supported living now than residential care. I think that's the first time that's happened since we've been here. We have got a real drive. I'm very passionate about people not living in residential care. Poorer outcomes for people who live in residential care. We don't start to think about how they can go to college, how they can do opportunities other than be living in residential. So I think it's really important that people, where they can, live in their own accommodation and have the opportunities that we all do. We also talked today about the technology-enabled care, and you can see that in the report the usage of this has really increased to 15%. That's exceeded the target for this year. And we've also just talked about the occupational therapy team and caretaker monitoring team, which are fully operational and improving the outcomes and early intervention for people. The second theme is around information and advice, and I'd like to draw out the fact that one of the things we've talked about in terms of productivity, and that's not because people aren't being productive, it's because demand is so high that we have to look at new ways of doing things in order to spread that resource across the new demand. So we are going to be piloted Magic Notes, which is our AI tool that enables people to use AI to enable them to take their notes, which gives them spending less time going out on a visit, coming back, writing it up, because that's done more digitally. That enables them to spend more time on things that people, practitioners want to do. So we are going to roll that out from September to everybody, and the feedback from people has been very good and positive about the way that's been piloted with people. And work has been underway to launch the unified Your Nots directory, which is combining the city and the county community directories. Really important for both the public but also for practitioners to be able to then know what resources are out there. The challenge for us is, with these things, is how we keep it up to date, and we are reliant on people inputting into that to enable us to make sure that it's a live document and is well used. The third strand is around active and supportive communities, and we've supported 624 adults into employment, education or volunteering by June 25, and we're on track to exceed the annual target that we've got of 825, so that's a positive. And people can, Ainsley is very involved in that with the team as well. And Brook Farm continues to support disabled young adults into employment and training as well. The flexible and integrated care and support, we've got direct payment usage that's remaining above the average for people under 65. So that's a positive thing. People have more choice and control when they have a direct payment to enable them. They also manage money, I would say better, because actually they see it as their own money and then decide if they don't want something that they don't spend it. And actually we do, you know, it's not that people keep that. At the end of the year, we do an audit on people's direct payments and that money comes back into the council. So that's also a positive. And the Community of Practice for Reviews was launched in September to improve performance. So people are doing a lot of work on how they can do reviews in a more proactive way. Some of the things that need to change, place-based working and redesign triage processes that support early crisis intervention is very hard, but we do talk to people a lot about prevention is better than cure, and so actually if we can get in early, if we can support people, then that's a good thing. Reablement and enablement services are performing very well, both rated green and on track to exceed their targets. This is particularly important for our hospital discharges, where hospital discharges are very good here, and our reablement service is very much linked to that. In terms of workforce, so we have had, well, the operational staff have had a bumpy ride in trying to get through everything that they've had to do over the summer and get into the redesign, but we're there, we've got people in the right seats and the right places now. And now it's the time of just tweaking and making sure that we've got everything right from that work that we've done with people. And then shaping future career development for people. And that platform is launched and has been well received from staff. Moving on to the finances, the forecast overspend at period 3 is 2.51 million. That's less than 1% of the overall budget. And please remember, this is a volatile budget because you can't control all of demand that comes in, and we have got an we do have to meet assessed need. Obviously, everything will be done to try and mitigate that. So we do have lots of mitigation plans in place. We have what's called the sustainability plan. And if we didn't have that, the pressure would be far greater. So we have to make sure that we stick with the sustainability plan in order to be able to come in on budget later in the year. We have got significant increase in costs since COVID. So everybody, it's not saying just not for Nottingham, but this is everywhere. The costs of care have gone up substantially. And there are other things that have gone up in terms of national insurance and also in the wages for people. So I'm not saying they're a bad thing, but they do cost. So council put in an extra 40 million into the budget last year. 29 million of that was directly passported to providers who had to then increase staffing costs because of national living wage and for national insurance. So that's all putting pressure on us as well as increase of demand, really. So that risk remains. I couldn't say to you that new demand is not is there. We are just learning new ways and how we can try and mitigate that demand, how we can get to people earlier, how we can make sure that people plug into communities, see what else is available, along also having receipt of services from ourselves, really. So I wouldn't say we're an outlier in any of that, and that's the same for the rest of the country. Lots of councils are struggling with their adult social care and their children's social care costs. Quite often it's about 70% of the council's overall budget is now spent just on social care costs across adults and children, which then also puts pressure on other services that councils want to provide with the rest of the money that they've got. So I'll leave it there and open up for questions.
Thank you. Any other officer with anything to report? Okay, we'll open the floor up for debate. Oh, sorry. Yeah, can we move the recommendations as detailed in the report? And I need a seconder, please.
I second it.
Thank you. Okay, yes, moving on, we'll open the floor up for debate. So, Councillor Gowland.
The hospital discharge data, I appreciate it's probably low on the national rate, but it does look like it's trending upwards. Is there an underlying issue here? Because, I mean, I would have thought June would be a good time, not a bad time. I appreciate it's 3 months, it might just be noise.
So overall, our hospital discharge rates are very good. We're above average in the country. I would say that the demand on that has gone sky high because actually the hospital is linked to the recovery plans post-COVID for hospital to get the operations and stuff. So a lot of that. But we do well, and we've been recognised for doing well in Nottinghamshire. So it's not a worry or a concern, really. No.
Any further questions? Councillor Rich?
I'm just going to push this out that thing. And I know adult social care is not sure about funding or budgeting or whatever, but this is the question I'm going to bring up anyway. So what specific activities are you being undertaken to address the 2.51 million overspend?
Okay, so if you think about it, essentially we spend money on two things. One is on staffing to enable us to do assessments of the things that you've heard about today. The others is directly packages of care. So the packages of care have cost more than they would do year on year. That's partly to do with the reasons I said in terms of national insurance and wages. We are legally obliged where assessment has taken place for us to provide that care. What we are doing is doing reviews and using things like technology and enabling people to have alternative ways of doing things. So it doesn't always work out, but sometimes you can have an alternative package of care that is cheaper than the package of care that you've got at the moment. Lots of the reviews will be doing that work. I mean, that's part of the sustainability plan, is to make sure that we try and constantly look at what costs are. Equally, our commissioning colleagues are doing work with providers to make sure that providers are doing all they can to make sure costs are kept down. And that trajectory of the fact that we are moving more people out of residential into supported living, all of those things. And you have to look at that over a long term rather than a short term, because whilst the cost of supported living these days probably costs about the same as residential, there was a point in time when people used to think it was less than residential, and that was possible for some high cost cases, but it's not always possible for the average cost of care. But it's the opportunity that brings to the individual. So the individual may move into supported living, their skills get better, they can then have opportunities either to go to college or whatever. They then might move into general needs housing. And so actually all the way along, it's reducing costs on us, which is what we want to do more of.
Councillor Wright.
Hello, Guy. Is there any new areas of risks developing that you've got concerns for moving forward?
I mean, they're quite significant in terms of the provider failure stuff. So the cost of care for people is going, through the roof for a lot of providers. Therefore, sustaining quality then is an issue. So making sure that we have to do our due diligence on making sure the quality of care is good and making sure that they can stand up as a provider. What we're seeing is more mergers happen, particularly between charities, than we would in the past. We had more, I would say, we've had more market failure in Nottinghamshire over the last 2 years, but I would say that's not high in comparison to other places. But we have seen it, and that puts demand on both the commissioning services in relation to the work that you have to do with people, but all the operational services, because all those people have to be reassessed and moved. So that's some of the pressures. Katie, did you want to come in?
Yeah, I'll just come in on that. I'd really want to say that our provider partners are brilliant. We've got a really mature relationship with our provider partners. Generally, our provision for people who need care and support, we've got a stable, sufficient market. So if you need support, you get it in Nottinghamshire. And actually, there are some local authorities that have got quite a lot of turbulence or haven't got some of the provision in place. So in Nottinghamshire, we've got a good provider market, in my language. And most of our providers are rated at good or outstanding. So that's a really important message. But as Guy's just said, we have seen some turbulence, particularly in some of our care homes, where we can actually show, and it's a message that we've given for quite a long time, is we have had too many residential care homes. Not in terms of residential care homes with nursing, we do still need a little bit more of that, but in terms of residential care homes, we have had, it's the one area where we've had some oversupply, and we know that some providers have struggled with under occupancy that have then impacted on quality. So we have, as Guy's just alluded, had to increase our resources, our teams, to be able to support where quality had got to an unacceptable level. We have a lot of risk management. We share a lot of intelligence with partners, with operational teams, so we pick up when problems are happening. We have supported 19 care homes to improve back to good quality over the last year, but we have seen a number of closures as well, and we've had to support people to move safely and effectively. So that's an area where we're very focused at the moment. But we have got loads of brilliant providers that we've got great working relationships with, that provide a lot of brilliant care and support.
Thank you. I'd add to it the complexity of people, though. I think that is one of the things that is driving up cost, and not having sufficient, daily Emma will come to me with a particular person that is actually quite difficult, come out of a secure hospital, for example, going into the community, trying to find the right provider, trying to find the right wraparound resources so that person stays safe, but also so the rest of the community stays safe, is complex. And so those are the increased demand that are most worrying, really.
Yeah, my concerns are earlier this year you had a company, Creative Care, that sold, merged, because of the financial pressure due to government. A wonderful idea of national insurance, and it's hit immediately, and that is a real concern for me moving forward, because I think that's just going to put massive pressure on us. So, you know, I'd like to highlight that for the record, to be fair. My concerns, if we've got to allow these partnerships, if they go, then we're in a mess. So that is a concern, but thank you anyway.
I would say adult services is very reliant on the external market to provide its support, very differently to children's services, although where children's services do, they are seeing the increases as well in terms of placements.
Councillor Cox.
Thank you. Guy, I want to start with the negative and then hit you with a positive, hopefully. Which areas are underperforming under the adult social care? Which areas are underperforming, and what we're putting in place to mitigate that underperformance? And then equally, as a positive, you know, where are we exceeding expectations, and what are we putting out there from a lessons learned point of view?
I would say our underperformance, and I'd say it's underperformance mainly on the outcomes that we want to get for people, not necessarily because of the workforce, but our ability to keep up with assessments and reviews at a timely manner. You know, we wouldn't want anybody on a waiting list, but we do have people on waiting lists. That's not because the workforce isn't working hard enough, just the demand and the amount of workforce that we've got doesn't marry with it. And so constantly trying to, there's a negative for the people who are not getting the right outcome at this time that we want to do. We are doing work on that to try and all the time trying to make those things easier and shorter, etc. But that's the negative, I would say. The positives, there are quite a few. I would say our safeguarding stuff is very good. Our continuity of workforce is brilliant, and the fact that we retain our workforce has to be a positive, particularly for the people who are seen regularly or years after year. Our discharge work with the hospital is excellent. Some of the provider services that we've got, and some things like the shared life service, etc. We have some outstanding rated services from CQC in that sense, really. So there's a plethora of stuff across the department, I would say, that we've got to be proud of, really. And it's really important that we remember those things, because we are about to have our CQC assessment, and in December they'll be on site looking at some of that, talking to our frontline, and hopefully we put our best foot forward and show some of the good things that we've got.
That's great, thank you, Guy. And just pick up on a point that you mentioned about the hospital discharge rates are being really high or good. How are we measuring that? Because I've a couple of experiences with my constituents who they firmly believe that they were released too early. And so what matrices have we got in place that ensure that they're not being replaced early just to hit the target?
And that's some of the things where, if you ever looked at data around delayed discharges, is what the technical term is, what it's called, quite often that might be us having arguments with health saying, actually, we don't think they're fit for purpose. Quite often a clinician will say that they're not fit for purpose to leave, and they're being pushed through because of this whole thing about trying to get people out of hospital. So it is an ongoing positive way of tension between us and health working on that, but we do look at things in different ways, and we are making sure that the person who's going out is safe, has got the wraparound support that they need, because actually a revolving door of going in and out of hospital is as bad for people as it is getting them out 2 days later and with the right support. So we constantly have that, and there is a belief that sometimes people think people are coming out of hospital, but if you look at the trends over years, people have spent less and less time in hospital over time, really. There will be a demand issue to that. The pressure on beds is huge. So.
Thank you.
Councillor Butler.
Thank you. Actually, my question's been pretty much picked up and answered, because at these meetings, there's always a danger of falling into the negatives and sort of what's wrong and what needs improving. And I was just wondering what we're feeling really proud of, but we're yeah, I've got that message very much. So really well done. But and also just going back to you've touched on it, but on the staffing side, are we pretty much up to compliments on staffing now, or have we still got any challenges in terms of numbers? Apologies if you mentioned that, I might have missed it.
So in terms of our operational staff, our social workers, occupational therapists and community care officers, while we were going through our redesign of service, we had a vacancy freeze because we were moving staff around. So we didn't recruit for a number of months. Between April up to the current day, we've had a huge recruitment drive and we've been really successful. So Maria said, I think we've got 2 OT vacancies, which is unheard of. It's fantastic. In terms of our community care officers as well, we recruit really well there. The key element we have as a local but also regional and national issue is experienced social workers. So tempting them into Nottinghamshire and so once we get them, they stay with us. But we're competing with our neighbouring authorities also for those, and we have a national shortage of them. So we do the best we can in that, in terms of our community care officers are really well skilled and trained and undertake a number of adult social care kind of assessment and review tasks and support for people in the community. And we really focus our qualified and experienced social workers on things like safeguarding, complex mental capacity work, court work, those sorts of, and those kind of that direct work with people and families where they have maybe multiple challenges that we're trying to overcome. So we mitigate that as much as we can, but we would love to have more experienced social workers. We do well for newly qualified social workers. We've got good relationships with local universities. We've got a fantastic apprenticeship scheme for our internal staff. So we see a lot of in terms of career development for unqualified staff to become qualified, and we support them through university to do that. And actually, they come out brilliant actually in terms of some newly qualified social workers who've been some experience and go through university and join us when they're quite young. Our community care officers who tend to go through the apprenticeship route tend to have been working for a period of time, quite a lot of life experience, and are absolutely fantastic once they've had the training as well and got their qualifications. So we've got some successes, but there are some significant challenges there as well. So we're continually thinking about new ways to recruit, to tempt people to come. So one of the key things that we're really proud of is about not working in Nottinghamshire. We're really proud to do that. And we really want to convey that out. So we do as much that can in terms of our networks, our regional work that we take place, and the national work that we take place as well as that we're involved with, is to really sort of showcase that Nottinghamshire is a great place to live, to work, and we support our workforce well.
And that's about the occupational therapy and social work service. But I'll also let Ainsley.
Yeah, sorry. Look, I'll talk about social workers and OTs all day. Let's let Ainsley talk. Apologies.
Just to add to Emma's point, so I think one of the things that we just need to reflect is that the adult social care workforce is really diverse. It's not just, and I don't say just in a negative way, I mean, not just about social work and occupational therapy. We've got service improvement, sort of market management, commissioning in Katie's area, and then in my area I've got people that deal with people's finances. I've got frontline care staff. We've got a really diverse group of staff who work in the department. Some of the pressures that I see in services that I provide, where it's frontline care staff is trying to compete with some other industries such as Lidl, Aldi, etc. Because actually often their pay is better, and our overall package may be more generous in total, but actually if you're living week to week, actually it's that hourly rate that matters often. So we do have roughly about a 26% vacancy rate in frontline staffing, which is always quite tricky to manage that. Sometimes we can cover with often additional shifts to existing staff, but sometimes we have to bring in agency staff, because the other thing with a lot of my services are they're regulated. We have to have minimum staffing levels as per our regulations, so we can't just say, oh well, never mind, we've got a vacancy for 3 months, we'll cope. We don't cope. We have to cover it. So it's a mixed picture, but I just wanted to reflect the diversity of the adult social care workforce, that it is quite broad.
Councillor Gowland.
Thanks. Just following on from that, with the staff, similar names next to
Just go back to press the button.
with the staff, with the reorganisation of service, the merging across the different areas. I mean, clearly there are benefits, particularly for the users in that age range. But has that had any impact on staff, in particular staff development and staff sort of ability to develop expertise in one area?
So it's a really good question because we've amalgamated what was our working age adult and older adult services. We had a really mixed picture in terms of staff skill set, experience and response across the county. We had some teams where we were still very much working in a small cohort of staff would be working with adults who have a learning disability, with mental health and with physical disabilities. And in other areas of the county, some teams had moved to a more kind of multidisciplinary and place-based approach. We took what we felt was the best out of that in terms of staff feedback, but also the outcome feedback for people, that actually a team that would kind of work around neighbourhood and place of staff with those skills in those teams to support each other and work with families as a whole has meant that what we would expect to see, and we're starting to see better outcomes. So, for example, previously I went saw a woman who has significant mental health problems. She cares for her son who has learning disability and autism. And so previously, in terms of there would be a social worker for her son and one for her. She's also an unpaid carer. So there's three hats that she's kind of wearing in terms of our service response. So so previously she had maybe three different people respond, depending whether it's a need for her, for a son, or as a carer. Now what that means is she can have one social worker that supports her and her son, understands their full family situation and can understand her needs as an unpaid carer. That means sharing of skills and experience. So we would expect that the most qualified and experienced member of staff would lead with that. And that would be someone, for example, in her situation who's got experience of working in terms of mental health and learning disabilities and would understand that full picture. Previously, there would be a different waiting time for her son to her because of different presenting needs. And now we can respond to all that better. In terms of we've invested in staff training, lots of budding and mentoring in terms of between teams and team members, and also our sort of advanced social work practitioners and advanced occupational therapist practitioners who will lead on that practice in terms of their local teams as well as support in terms of different legislation perhaps and presenting needs and how to support that, and also which organisations are available to help, whether it's with health colleagues, district and borough councils, thinking about our providers, but also community and voluntary sector as well. So those connections as well, and making sure that they've got those that information to hand.
So just, I understand that, and it makes complete sense in that case example you make. I'm just thinking 5 years down the line, where will you get those experienced people with expertise in mental health, social work, if they, you understand?
Yeah, no, I do. So we'd expect that in terms of our training, we would keep that sort of training up to date. We also do have some teams who maintain some specialist working. So in Ainsley's area, we've got our approved mental health practitioners service. So in terms of undertaking mental health act assessments, they provide support and guidance to our to members of staff who perhaps got more generic skills about working with people in terms of particularly mental health crisis. And also in terms of our training, our support, but also in terms of the post-qualification support that our occupational therapists and social workers do, whether to become an approved mental health act practitioner themselves, so really becoming a specialist in mental health law and practice, or a best interest assessor in terms of mental capacity, which would be working broadly with older adults who may have capacity issues around dementia, but also adults with a learning disability, potentially who may require support around making decisions. So there's something about our training, our investment in our staff, and also rather than be a dilution, a sharing of skills and support. We talked a bit about how diverse the adult social care workforce is. We have people who come in for all sorts of reasons. Lots of the time it's because of personal experience in terms of might be caring for a relative or might have a sibling with a disability. So people come in with an area of focus and real passion, and we want to encourage people to continue to work in that way. But we also need to respond to people's needs fairly and equitably and get to them as soon as possible. So it's how we can be a bit more strategic about how we use our staff in that way.
Councillor Gerling.
Yeah, thank you, Chairman. This is really to put some perspective on it, because it's about finances and risks and things like that, but you might need your calculator. So this overspend, what is it in relation percentage-wise to the total budget for adult social care and health? Because I think that just puts a bit of perspective on on the issue really. And I've been a councillor for far too long really. Some would agree with me completely there. We know how it fluctuates, and we're coming up to winter. So I'd just like to bring up the fact that what impact do you see winter having on our budget and our overspend, so that when we come to the Q2, Q3, we're more prepared for what it's likely to show. I think that'd just be beneficial for people really.
So the percentage at the moment in period 3 is 0.79%, so that's less than 1% of the overall budget. Winter does have pressures, and what I would say is it's also about the system and what happens in the system that puts pressure on us as well, so which is not what we can all control. We're currently having a conversation with health about the withdrawal of funding from health to some of the reablement services that they provide. The reablement provision probably won't, the need probably won't change, but if the service is changing, it will have an impact on us, and that can have an impact on discharges, it can have an impact on how quickly people get well after operations, etc. So we're constantly having those conversations with our partners to make sure that their decisions don't have an impact on us, but everybody's under that squeeze of having to cut things, so the ICB has got 50% to cut out of their budget. So I think it will have an impact on winter, and I think we will see increases both in demand. Sometimes it depends on how bad the winter is. So there are elements of you may have increased deaths over winter, but you may have increased falls. Both have a different consequence in terms of cost.
Jim, it was more to give the perspective of how it can fluctuate. So while it's looking relatively good, even though £2 million is a lot of money, it's 1% of your overall budget, and it just puts a bit of perspective on it really, and the fact that it's likely to fluctuate. We ought not to sort of start panicking and pointing fingers because it fluctuates. But we should know that and understand
that. Councillor McCormack.
Just like to pass on the message from Councillor Gould that she's had to leave earlier and offers her apologies.
Yeah, thank you. Okay, right, Martin, anything further to add? Excellent. All right, okay, we'll note the recommendations have been moved and seconded, and we'll take a vote with a show of hands. Cool, thank you very much. And our final item on our agenda today, I know it's freezing in here, really, isn't it? So we're glad to be moving on, is the work programme, which Martin will very kindly run through.
Yeah, so just note that the work programme has been developed in a cross-party way, and it went really well this year. It was approved at Overview Committee last week, so you can see it's quite full. We've tried to keep it manageable, so there's only like 2 or 3 items of the meeting, and as we found today, 3 items of the meeting is quite enough. So we've tried to keep the meetings manageable so you can have a good discussion, and there's also some areas being highlighted for some reviews as well, so we'll be developing those as the year goes along. As always, if you do have any further suggestions throughout the year, let myself and the chairman know, and we'll look into it for you.
Thank you, Martin. Councillor Answer.
Thank you, Chairman. Basically, obviously looking at the forward plan, we so that you're all aware that we've got the CQC coming in to inspect adult social care on the 15th of December. Your meeting after that is on the 17th. Obviously, it's going to be a while before we get a report, but we may have a feeling or some thoughts. You might want to at some point put that onto your agenda, because it's important that you have a full feedback of what the outcomes and how we feel about it. Thank you.
Yeah, that's on the because of the kind of like the timing. I think it was agreed that we'd have a briefing for members, so they got briefed as soon as the outcomes were available, right? Because it's December, the next meeting isn't until March, it'll be a long gap. So as soon as there's stuff that you can share, we can have a briefing for members.
Thank you, Martin. All right. Okay, just want to thank the Cabinet members. Sorry, go on.
I think during the meeting, Councillor Smith asked that one of the assessments was brought on to in 6 months' time.
That's been brought on.
it's going to be on in March.
That's going to be in a future session. Yes.
Yeah, brilliant.
Yeah.
Thank you.
Okie dokie. Yeah, I'd like to thank the
Sorry.
cabinet.
Sorry, just one point.
Go on.
Sorry. I know we all want to get out. Not necessarily a work item, but maybe if the committee can organise some visits to see the frontline service, which might bring the work to life, particularly the technology stuff. As I said, when I was the leader of the council, it was definitely the most interesting and phenomenal visit I did, because it actually brings to life what we're doing. And we spend £350 million a year on adult social care. It's really important that members of the committee understand where that money goes. So it might be interesting if some visits can be set up.
No, I agree with that. Thank you for that suggestion, Councillor Smith. Okay, so try again. I'd like to thank the cabinet member and the officers for the 3 really detailed reports that you brought today. You can see that a lot of work has gone into them. You can see that real progress has been made in supporting people of all ages through the Carers Hub and the excellent work with young carers, all of which ultimately make a big difference to people's daily lives. Occupational therapy report, again, that was really good, and the new countrywide service is clearly embedding a therapy first approach, and will cut waiting times and helping residents to remain independent and in their own home. So that's really good. Consistency and prevention focus and good use of technology is ultimately going to serve the residents well. Finally, adult and social care performance. While there are positives in safeguarding and re-ablement, I want to note to the committee that the number of adults in long-term residential and nursing care is still obviously on the RAG status, is red. So I think this will be something that the committee will look forward to seeing improve over time. And finally, on behalf of all of today's committee members, I want to thank you all officers involved, for the reports and for the difference that the services are making across Nottinghamshire. So thank you.